Good afternoon, everybody. This is Debbie Plotnick, and I'm here at our national office in Alexandria, and I thank you all so much for joining this afternoon in our joint RPC cluster call. We're going to be recording today's presentation and conversation. The recording and the slides are going to be on our website by Thursday. Yay to Karen, who's going to get that out for us. And I want to get started here by doing what we usually do when it's an RPC event. We thank our sponsors because we truly appreciate the sponsorship that allows us to hold the RPC, to do the calls, the meetings, and our webinars. So thank you. You can see our sponsors on the screen, and we appreciate it. Today, we have two of our amazing RPC representatives who are going to be leading the discussion and presenting during this slideshow presentation. We have Ben Harrington, who is the Executive Director of MHA of East Tennessee, and Shell Gross, Policy Director of MHA of Wisconsin. And we can, if you go along and have a question as we're presenting, please feel free to type it in the chat box, and we will get to it at the end, as well as unmuting everybody so that we can have a conversation. So I just want to tell you a little bit about today's objective. We're gonna learn together about what we know thus far about Medicaid work requirements and the guidance that was announced by the administration in January of this year. We're going to understand a little bit more about work requirement efforts and the effects that such work requirements will have on people with mental health and substance use conditions. We're going to identify some other access to coverage issues. We'll touch just lightly on some of the other issues that have arisen around folks with mental health and substance use and their access to coverage. And we're going to learn together about how to create a winning strategy for talking to state legislators, talking to our federal legislators, and putting together a constituency to address some of the issues that will come up. Next slide, please, Karen. Thank you. So you guys know about Medicaid. You know, it's Section 1901 of the Social Security Act. You can read the definition right up there on your screen, but we also know who it is that was covered by traditional Medicaid. We know that the categories as they are outlined are folks who are blind, folks who are disabled, pregnant moms, people with children who have a very low income. But under the Affordable Care Act, Medicaid created an expansion population, and that had only to do with whether or not folks had a need for coverage and met income requirements. So we'll be talking about folks in the traditional Medicaid population and the expanded population today. So one of the things that is most important to the states and to your affiliates are the 1115 demonstration waivers. Okay, we know that whenever there's a waiver, states have to show that it's necessary, that it's experimental, and that it will promote the objectives of Medicaid, such as expanding coverage or access to care. So the work requirements would need to be a waiver. That's not in the original law. We know that states will have to ask for permission. We'll be getting into how many states have asked thus far, and we expect them to be others. So we're going to have to be talking about waivers, and until this point in time, we have not had, until this administration, any waivers for a work requirement that has been approved. The administration that came into place last year stated that they were in favor of work requirements, and we have just had some of the states being granted those waivers. Those waivers can make it harder to qualify for Medicaid. There's some new eligibility requirements Again, it could be a work requirement. We've even seen drug testing as one of the requirements. And also we've seen requests to set time limits as one of the things that the administration would like to see. So under this administration, the objectives that were put forth and stated by the Director of Health and Human Services, by the Director of the Centers for Medicare and Medicaid, include from the administration itself the repeal of the ACA. We know that both CMS and HHS have asked for more flexibility, and Director Verma from CMS has said that she's going to fast-track waivers. I have been in several meetings with her this year where she said we're going to go from being the agency of no to the agency of yes, and we have seen that happen. We know that some of the attempts that the administration has put forth to repeal the ACA have not worked, but we know that they keep coming back in many different ways to repeal some of the pieces of the ACA. There were quite a few bills last year. We've seen in budget bills. That has not happened. I want to stress very strongly that the Affordable Care Act is still the law of the land, and that's very, very important, but there have been some things that have made it harder for people to get access and that have chipped away at some of the pieces of the Affordable Care Act. Can you go to the next slide, please? Next slide. Oops. I'm not chipped into that next slide. All right, there we go. There we go. So what are the ways that some of the access to coverage has been undercut? Well, we've seen a reduction in the cost-sharing payments that come from the federal government. We've seen, in fact, some talk about not having any cost reduction. This goes a little bit back and forth, something we're watching. The individual mandate that says all people need to have insurance has managed to get in there in the jobs cut bill, that people are no longer required. That's an issue that will leave a pool of people who are a little older and a little sicker if young folks feel invincible and don't have the need for insurance. We've seen some changes with respect to some unusual insurance vehicles, and I'm just going to touch on this because it's very relevant to getting folks mental health and substance use services in particular. Two types of plans that are available in the private market are short-term plans, when somebody needs just something to tide them over between jobs or between eligibility periods, and association health plans. And the reason it's important to talk about them is under their rules, there are ways to have them avoid the essential health benefits, meaning that these short-term plans and association health plans do not have to cover mental health or substance use services. They also don't have to cover maternity benefits and perhaps some others. The biggest change that has happened with respect to short-term plans is that they used to just be short-term, and they were only for a few months. That has been extended to up to a year, and this is the most important piece, they are now renewable. So what that could mean is that you could have it for a year, you could renew it, and there doesn't seem to be any end date for that renewal. Association health plans, again, don't have the essential health benefits, and it allows groups of people who are very loosely associated. It might be just all the uninsured people could come together, whereas it used to have to be you all belong to a particular trade association or a group that was a union or something else that people were associated with. Now it's much looser definition. So these are the other issues that we need to take a close look at. Now, I mentioned a minute ago that the ACA is still the law of the land, and we're going to work hard to see that it remains so. And we had an example recently where the state of Idaho tried to exempt state-based plans. That means plans that just were in Idaho from ACA requirements. The requirements they wanted them to not have to follow was community rating, maternal coverage, lifetime limits, no-cost preventative care, and pediatric care, dental care, etc. So what we found was that they wanted to, in many ways, go back to the bad old days before the Affordable Care Act. And CMS did uphold the law and said, nope, you can't do that. You are not allowed to violate the terms of the Affordable Care Act. That said, there was a suggestion made to use short-term plans instead, in which case they can still skirt the requirements of the ACA. So CMS issued some new guidance on January 11th that allows states to create work or so-called community engagement criteria. Their ostensible purpose is to help families ride out of poverty through work promotion. We all think work is a wonderful idea, and we certainly want to see ways to do that. Do we have the next slide? Thank you. So many states are requiring or considering requiring work requirements. Some of those states have not expanded Medicaid. Some of those states have expanded Medicaid, and the states that have requested applications for work requirements are Arizona, Kansas, Maine, Mississippi, North Carolina, Utah, and Wisconsin. And they have some, we'll hear more about what some of those states have in their requests. Some are unusual. Like all things related to Medicaid, if you've seen one Medicaid plan, you've seen one, although there are a lot of consistencies. We know that other states are planning to ask for work requirements for their waiver for their Medicaid plan. That includes Alabama, Louisiana, New Hampshire, Ohio, Pennsylvania, South Dakota, South Carolina, and Tennessee. And in Pennsylvania and Tennessee, they've had bills in their legislature that are introduced to get this moving along for the waiver. Next slide, please. So let me catch up with myself here. What's considered work? We're going to hear about that from Ben Harrington. Ben, you're on.
Thank you, Debbie. Pleasure to be on the phone with folks. You know, a work requirement naturally is going to include actual hours of real work somewhere, somehow, wherever it may take somebody. Different states are looking at different requirements. The majority of the states that Debbie referenced in the previous slide are leaning more towards the 20 hours of work per week requirement, although there are, you know, outliers on both sides of that. For example, beyond the 20 hours, the state of Michigan is talking about a 30-hour work week with a limit of 48 months for that time frame and amount of work as someone is eligible to stay in their program. And the state of Alabama is even beyond that, and they're looking at a 35-hour requirement. Much more generous would be the state of Indiana, which is in the middle of your slide there, and they've labeled theirs as up to 20 hours a week. And what that means is they're recognizing that some folks may have readiness that's not quite ready to go back and work 20 hours a week, but maybe they need to start at 5 hours a week and then 10 hours and 15 and actually take a graduated amount of time up to 18 months to get to that 20 hours. So that's much more generous than some states are considering. What also qualifies beyond actual employment would be the work-like community engagement activity that CMS has referenced. And for some folks, that's going to be time actually spent searching for a job, doing some job training, developing some skills to help them land a job, volunteer work, or even education, like working on a GED or some college-level classes, that sort of thing. What's really important for us to consider and to keep talking with states about is very few seem to be contemplating what real assistance they have to have available to help a person navigate back into the workforce, to help find them find a job or provide them the real training they need, real skills they need to be employable. And that's really important for us to speak to in the future. Next slide, please, Karen. Okay, so CMS issued guidance in January, as Debbie mentioned, and CMS did point the way a little bit in their guidance, although I've got to tell you their guidance is a little bit vague in some ways. It did specifically identify there should be excluded populations from the work requirement, those who are pregnant, those who entered Medicaid because they have a disability, and that was their portal of entry into Medicaid, those who are seniors and those who are medically frail, as well as those who are dealing with a substance use disorder like opioid disorder or other addictions. Those were specific things that CMS said should be exempted. Now, they also pointed out in their guidance something important. They suggested states look really closely at the SNAP or TANF work requirements and link to those where possible. Now, CMS is being, I think, kind of prudent in that regard. They're suggesting states save themselves some heartache and save all their enrollees, whether it's in the SNAP program or the Medicaid program, dual reporting or dual applications, that sort of thing, even potentially saving resources for a state from having to build a separate infrastructure. Now, all that said, what CMS did not do and didn't get real specific about was they didn't name anything specific regarding mental illness in their guidance. So they didn't use that phrase. They didn't get serious about identifying family caregivers of children under a certain age or family caregivers of an adult with a disability or anything like that. All of that leaves lots of opportunity and fertile ground for stakeholders and advocates to help shape where their state goes, if their state is going down this trail, to help guide them to creating a program that's going to best serve their residents. Next slide, Karen. So we have here a couple of examples, or three examples of what some states are doing. And Kentucky and Indiana have chosen to mimic each other a fair amount. They're exempting children and exempting students in Kentucky who are full-time students and pregnant women, and caregivers of children of a certain age and caregivers of adults with a disability or who are medically frail. A key group here that needs to be further explored at every state level is this group of people that is called medically frail. And each state is going to define that in a certain way, and each state may arrive at that definition looking at a variety of things. For example, Kentucky is interested in churning utilization data to see, does that show how frail someone is? The units of service for health care, mental health care, et cetera, does that really paint the picture? It may not be what really paints the picture for them at all, but that's something that they're considering. But so medically frail as a population is one we all have to explore. People in active SUD treatment, well, what does active mean? Active could mean, engaged in current treatment, or they've been in a residential treatment program in recent months, that sort of thing. Arkansas has similar things that they're looking at, but they're also leaning a little bit more heavily. Those bolded items there on that side of the slide are much more in alignment with the SNAP requirements in the SNAP work program. So Arkansas is leaning a little bit more that way. But every state gets the opportunity to create their exempt groups. And I'll take you back to under the Kentucky-Indiana slide or portion. And the third one from the bottom is Indiana wants to exempt youth who have aged out of the foster system and are under age 26. So every state will have those opportunities to craft exemptions that apply to them. And I think that's really important because each state might have some nuances to try to work to better support folks. So next slide, please, Karen. Okay. So one of the things to look at here as every state goes about this is, as I mentioned, medically frail is an important category to zero in on where you can spend some advocacy resources. Both Kentucky and Indiana identify that the seriously mentally ill population will fall in the medical frail group. And that's really important because that means people with depression, anxiety disorder, bipolar disorder will be in that exempt category. Now, they may not have been disabled by their illness, but they're still going to be in that exempted group. And that's important because some folks are able to work and some folks may not be so ready to work, but we don't want to force folks into the work pool if they're not quite ready. Every one of those three states that are on that slide, though, Kentucky, Indiana, and Arkansas, has done the next step. In their waiver, they have asked for and gotten the ability from the federal government to charge a premium to their Medicaid enrollees. And so this means they're making their enrollees be accountable and put some skin in the game, and hence they're buying part of that service. And it's part of the belief or mindset that if someone's paying for something, they're going to be more responsible, they're going to show where they're supposed to be at appointments, that sort of thing. All that's good, but if you're building a program and you're putting work requirements in and payment requirements in, there's a level of accountability. And what happens when folks may miss a premium or folks are not current on their work reporting? Work reporting is going to be, if I'm working 20 hours a week, I've got to meet the guidelines required by my state to report that. And so Kentucky is a monthly requirement to report. Indiana might be every 6 months they want to report. So it doesn't matter what your state is. If your enrollee is not doing their reporting, that could be an area where they end up getting locked out of their Medicaid program because they haven't met the reporting requirement. The same is true with the payment of premiums. If they're supposed to pay a monthly premium and they don't pay the premium for some reason, they forgot, it snowed and the mail was delayed or something like that, that could then be an issue that locks them out of receiving services in Medicaid. So those are some things we're looking at that you can exempt populations with inclusion in the medical frail group, but you can also lose some services by virtue of non-payment or non-reporting. The other way you can get in trouble, difficulty here is, well, what if someone does work, and what if they end up earning too much money? Well, now that sets them up for disqualification from the Medicaid program because of their income level. So that's some ramifications there. Next slide, please. Karen, next slide. There we go. Okay. So what are the trade-offs? The trade-offs are this, is we dealt with all the discussion last year about repealing the ACA and all that stuff. A lot of states weighed in saying they really wanted have less direction from the federal government telling them what to do, but they wanted to have control at the local level. So states who go down this road and create a work requirement are going to get more control. They're going to be able to craft the specifics of their program and craft the specifics of who the exempt populations are and what the accountability actions are in terms of if you report or don't report and what happens to you. So that's what the states are getting. They're also getting the ability to tell their base that enrollees in the Medicaid program are no longer getting a free lunch, but they've actually got some skin in the game. And so that's really important for some folks. Of course, the states are going to get the ability to lock people out who are non-payers of their premium or fail to report. And you know, the bottom line here is if a state gets to disenroll someone for a time frame, lock them out, or they disenroll because they've earned too much money, that allows the state to do something that a lot of states want to do, and that's shrink their Medicaid programs. Now, flipping that coin over, there, of course, is a little bit of benefit for the stakeholders and people who do need services. Some of the states that have done this or are looking to do it are Medicaid expansion states. So, of course, those states that expanded their Medicaid programs, they're serving more people. But interestingly enough, a few states that didn't expand previously are now taking another look at this and seeing the Medicaid work program as an opportunity to expand Medicaid and serve people a little bit more, especially if we can get those folks to pay premiums and have some skin in the game. That makes it a little bit more palatable in some real conservative congressional districts. The other thing that's a possibility there that's a distinct trade-off is, you know, some states may be heeding advice of stakeholders early on in the process. If we're going to expand or if we're going to create a work requirement, we need to be looking at expanding, you know, the supports to help people search for jobs, find jobs, get trained, and be really ready for gainful employment. So that could be some gains for us. And, you know, with regards to MHAs, here in Tennessee, we're talking about let's increase the intentional peer support program in a big way. And, you know, so that may be something that ends up happening because of some advocacy. The other thing that's a trade-off and a benefit is some states are investing or getting in their waiver the ability to provide substance use treatment in facilities larger than 16 beds. So the last thing I need to mention, because Karen has moved that slide for me, is what it's going to cost us. The costs from this slide, you can tell, are all over the map. A high of $600 million in Pennsylvania. Pennsylvania realizes they're going to have to invest some significant dollars in the infrastructure for verification purposes, but they also, I think, are the only state that I'm aware of right now talking about investing some resources in the supports. And that's important because obviously, you know, some folks are going to need to be supported as they start to make their way into the workforce. Kentucky is looking at a $374 million cost. That's over 2 years, so about $180 million a year is the cost. They are putting their dollars into a new computer system that's really there to track compliance, folks, and track compliance in terms of did Ben pay his premium, and as he paid it every month he's supposed to. And so at what point can they have their computer system boot me out for noncompliance? The same is true with any of their work reporting requirement in terms of how many hours a month I'm working, that sort of thing, or how many hours a week am I participating in community engagement activities, all of that. That's what they're spending their dollars on. Now, at the bottom of that chart, you look at Tennessee's $38 million, and that looks like a bargain compared to what Pennsylvania's doing. Well, part of that is because Tennessee's already, you know, like 3 or 4 years into its huge investment to build a better verification system. So we don't have to really put a ton of money there. But $38 million is what needs to be allocated to build another avenue in our verification system to collect all this work history or community engagement history or history on the exemptions that can protect somebody. So that's where the $38 million. Now, it's asterisked there for a reason. In our budgetary process, it naturally would raise concerns at the legislative level, and the folks almost didn't vote for it until some folks got real cute with a workaround and called Washington and got tentative permission to raid, and I said it, raid, R-A-I-D, raid our TANF reserve funds to use those dollars for some of the infrastructure costs. So in essence, what it becomes is budget neutral in the state of Tennessee. Debbie, back to you.
Thanks, Ben. And Wisconsin hasn't reported what it would cost for them. So that's why we have no dollar amount there. These are really important items. An important point of advocacy is that it's going to cost states a lot to implement work requirements. And the question then is that expenditure on the state part's money well spent? Could it be spent for supports, supported employment, other kinds of health care, and things like that? So thank you very much, Ben. Beyond the work requirements, there's been some things that have come up in waivers. For example, Arkansas, which did expand Medicaid, asked in their waiver if they could lower the threshold at which people were able to come in. So nobody above 100% of the federal poverty level, not up to 138%. So could they be in the population, fewer people in the expansion population? And that would have knocked 60,000 folks from the rolls right away. Now, Arkansas was denied that request because the Affordable Care Act says 138% of poverty. So we know that there are some other things. Go ahead, next slide, please, Karen. So one of the things that it's really important to mention about Kentucky in particular, the administrative costs, as we saw in Kentucky, are very high. They could be directed to health care. But we also know that a lot of this money is going to go for infrastructure, and this is an unusual situation. The governor of Kentucky has stated one of the reasons for Medicaid work requirements is to lower the number of folks on Medicaid. It's estimated that it would be about 900,000 people who would be lost from the rolls because of the difficulties coming into reporting on the work requirements and the other requirements. There's also a lawsuit against Kentucky that is currently pending. So we're keeping an eye on that, and other states may have lawsuits coming as well. So just wanted to touch on very, very briefly, no, Shell's going to do this slide. Shell's going to talk about what happened in TANF when we had work requirements imposed. So Shell, take it away, please.
Yeah, thanks, Debbie. So we've been focusing up to this point on really what's being proposed, what are some of the details of how all this would work. And so we're going to switch now to look at the potential consequences and then what affiliates and advocates can do. We don't know, of course, exactly what will happen if Medicaid adds work requirements, but we can be informed by the experience of those who were involved in both SNAP and TANF, which have had work requirements for many years. And then, so on this slide, you can see information about what happened in TANF after work requirements were imposed. And what happened was that people lost benefits. So part of the reason we're concerned about this is that experience in TANF. But not only that, those people who worked and maintained their benefits, what they found out about the work is that while there were employment increases initially that were modest, those really decreased over time. The work requirements did not increase stable employment in most cases. And for the constituency we're most concerned about, those with mental health or physical health conditions that are barriers to work, they did not find work just because there were work requirements, of course. And then most recipients remained poor, and that's because those recipients on TANF, as well as those on SNAP who were required to work, were still working in low-paid jobs and mostly without health benefits. So they were not getting to a point that was significantly more self-sufficient. Lost benefits after SNAP was implemented were documented in Kansas. After Kansas passed requirements that non-disabled adults receive SNAP, work at least 20 hours a week, participation in the program fell from about 30,000 to about 8,000 over the course of a year. So we have reason to believe from those programs that there will be these negative consequences. Now the next slide here shows what we know is that the impact on people with mental illnesses will not be trivial. The numbers here are not surprising. Many people with mental health conditions may be limited in the number of hours they're able to work and therefore have lower income qualifying for them for Medicaid under the expansion. During the development of the Affordable Care Act, we were actually expecting higher levels of people with mental illness in the expansion population. And of course, they may be there, but they're not captured by these data because they didn't have a diagnosis or hadn't received mental health services. But we know that a big chunk of this population are people who have mental health needs. Next slide, Karen. So we also know that even though they have these needs and even though we've seen that people with mental health disorders may be exempted, the exemptions may not help. A key factor in whether or not exemptions for mental health will help these individuals is how the exemption is defined. Will people need a diagnosis? As Ben noted, in Kentucky and Indiana, it will include people with serious and persistent mental illness, but we know people with other mental health diagnoses experience significant challenges with work. Will they be included? What documentation will people have to provide to get the exemption? Many people who might qualify for an exemption could have trouble proving it depending on these factors. The fact that the impact of a mental illness on work can fluctuate over time may also create challenges in meeting exemption requirements or in jeopardizing eligibility if a recurrence of problems leads to job loss. Mental illnesses can, of course, at times interfere with thinking, with executive function, which are skills needed to meet documentation and reporting requirements. And of course, some enrollees may be reluctant to disclose their condition and forego applying for an exemption. And not the least important, we know that many of our folks with mental illnesses are disproportionately affected by other barriers, such as past criminal justice system involvement, which could jeopardize their work opportunities. So as we start to move to thinking about what affiliates can do, a key recommendation is to promote ways that states can support work, and we've already been alluding to this. We know that many people with mental illnesses want to work, but often require specialized training and support for this. In Wisconsin, our mental health authority worked with our Division of Vocational Rehabilitation to receive grant funds to train staff in psychosocial rehab programs to implement individualized placement and support, which is an evidence-based supported work program. The activities involved in implementing this are generally covered Medicaid services in these programs, and the employment rate among individuals in those programs has increased subsequent to implementation. So we know that providing these services can increase employment without having punitive sanctions. We also have to be reminding our decision makers that transportation and child care can be significant barriers for people trying to work. So what other sorts of things can you as affiliates do? The waivers process itself provides opportunities for advocacy. 1115 waivers require both a minimum 30-day state comment period and a 30-day federal public notice period. Affiliates can comment during both of these open periods. There'll be some sort of usually online ability to do that, and you can be pointing out problems with your particular state application or be advocating for changes to the exemption requirements to make them broader to include our population. During this time, or even prior to it, if you are privy to what's being developed, you can meet with state agency staff, especially to address these exemption issues and the process for determining who will be exempted and the process for determining how those exemptions will be administered. You can, of course, seek to have people with mental health and substance use disorders included as part of the medically frail population. And you can also really ask to be involved in developing those policies that will need to be fleshed out during the process if such a waiver ends up getting granted. As all of you know, if you're not at the table, you're on the menu. So really look to how can you be involved. Additional things that you can do, you can be asking about the budget and cost estimates for the proposed waiver. We talked a little bit about what the costs were. You saw in Wisconsin, they didn't address that at all, and that was a major emphasis of our comments. There are costs to this. We need you to be looking at what those are. Try to make sure those are made transparent. Budget estimates should also be addressing what the state's expectations are around how many people will lose Medicaid as a result of the new requirement. So you really want to be pushing to make sure that information is made public so people are really understanding what is it we're asking for here. As we mentioned before, there's a medically frail issue. At a broader level, you can be working with other advocates to push for Medicaid expansion as a ballot initiative. And maybe as part of that, you can explicitly prohibit your state from implementing a work requirement. And then you can also be informing both your decision makers as well as the public in your state that work requirements are not proven to increase workforce participation. So to really get at and make sure that everybody is aware of some of this information that we have been presenting you. Next slide, Karen. Of course, we've mentioned funding for employment and training. This is what has happened with employment and training under the federal workforce funding that in part funds vocational rehabilitation services. At a time when we're asking people to work more, the federal government is providing less money for employment and training, and oftentimes states are not including that as part of their package, and yet we know that that is critical for our population. Now, a lot of what we've been talking about is what can you do in the context of the waivers and how to improve what might be there, but there's also messaging that can be done more generally to really push back on the whole idea of work requirements. So I was able to attend a webinar last week during which the Center for American Progress reported on a survey they conducted around messaging on this topic. It was an online national survey of 2,000 registered voters. Representative sample with some oversampling of African American registered voters, Hispanic Latino registered voters, and millennial voters aged 18 to 34. I think what they found was very interesting. First of all, when voters understood what work requirements meant, they tended to oppose them. So if you just use the term work requirements, often people say, yeah, that's fine, people should have to work. If you say, I oppose denying Medicaid benefits if people can't work a certain number of hours, people think differently about it. They say, oh, you mean people on Medicaid have to work in order to get their health care, and not so supportive. They also found that along with opposing the benefits, you should propose something positive. And in this case, their recommendation is totally consistent with what we've been talking about so far. Is don't just talk about opposing work requirements, talk about increasing support for people who want to and are able to work. And that includes both those work supports as well as transportation and child care. Another thing they found is don't appeal to pity. Talk about assuring basic living standards, putting food on the table and a roof over our heads. But disability is a powerful lens for talking about this, So if you talk about requiring people with disabilities to work in order to get basic health care, people will hear that, and people do not support that. Underlying the support for these messages is something in another part of the survey. Only 19% of their survey respondents said, I don't envision ever being in a position where I would need or want to use the health care, nutrition, housing, or income support offered by the government. 65% said, even if I may not need them now, I'm glad our society provides government services to ensure basic living standards for when times get tough. Half of the people strongly agree with that statement. So people in our communities understand why we have these programs and why they're important. Last slide I want to talk about is this one, that most adults with Medicaid work. Estimates suggest actually about 60% of adults on Medicaid work. As you can see from this slide, the people who are not working are ill or disabled, they're taking care of a home or a family, they're going to school, they're retired. In fact, all of those are areas that are subject potentially to exemption. So most people are either working or subject to exemption. So what is this all about? Back to the Center on American Progress survey, when they asked their survey respondents, which of the following do you think is the primary reason that these requirements are being proposed, 45% said that the President and Congress are concerned that these programs create dependency and they want to make changes to lift more people out of poverty. The 52%, a majority, said they do not like these programs for low-income people and want to cut them to help pay for the tax cuts for the wealthy that they recently passed. As you may imagine, subgroups who are African American, Hispanic agreed much more strongly with that second statement. So what we see overall from the data is people work or people are already in categories that are potentially exempt, and yet this is being pushed ahead. So there's important messaging to do around this, and the public is receptive to that messaging. Back to you, Debbie.
Thank you, Shel. Thank you, Ben. Thank you to the 47 people who are on the call. We're going to unmute the line, and Karen's taking care of that right now, so it may just take a second to do that. So again, thank you all for joining us. If you would like to ask a question, we're going to try to have it not be muted. Why are they muted? And in fact, we're going to unmute you.
There you go.
Okay. We've got you unmuted now. If you would like to ask a question, please start by saying who you are, and we've got our experts here, and everybody will do their best to. Karen's also going to try to do it where you can raise your hand in a queue if it gets a little clumsy, but let's just start. Somebody want to start with a question? Dial star 6 or what? Oh, you could push star 6 to raise your hand, but everybody's unmuted, is that correct? Yeah. Okay, so folks on the phone, are there some questions? I'm not hearing anyone yet. I know 46 of our folks out there, Okay, let's try it again. Marcy has a question. Go for it, Marcy. We can't hear her. Marcy, hit star 6 and unmute yourself. Does that work? And then hopefully we can hear you. We don't want folks muted. We're working on it. Bear with us 1 second, please. Okay, should be unmuted. Marcy, you want to try again for us, please? All right. Karen's going to do it manually. Marcy, ask your question, please. Still can't hear Marcy. We've got a question in the queue. Shell, do we have a question that has been typed in? Nope. Karen, can you? Thank you for your patience, folks. We're trying to work this out. Technology. Okay. Can our participants speak to us now? We're losing folks. Okay. Would people like to try typing questions to us through the chat feature? And we will be happy to entertain them that way while we figure out our logistical questions. Okay. I don't have anybody in the chat function other than asking about the slides. And yes, the slides will be available, but we really do want to hear from you. So if you'll bear with us, we're going to try to figure out our logistical problems.
Test.
Marcy,
can you hear me?
Are you there? I think we can hear you now.
Yay! I'm driving. Sorry.
Yay! Go, Marcy.
My question was how we can help from Kentucky other folks message so that they don't have to do this. So is there any specific way that folks need us to help them work on messaging around this?
Can we get input from other people? Okay.
This is Shell. I would say if you have developed any messaging pieces and you want to share those with Debbie, then we can get them out through the Regional Policy Council.
We appreciate that Kentucky has really been looking at these issues. Kentucky has also in their requirements some of the most stringent reporting requirements. Marcy, tell me if I'm correct. My recollection is that it's every 10 days to report your employment status.
That is correct. Every 10 days, and you face Medicaid fraud charges if you do not.
Right, so that's really, really stringent. So, and was I mistaken in my figures about how many folks are going to lose Medicaid coverage in Kentucky? Karen told me that I was off by an order of magnitude, and I certainly don't want to be.
The estimates have been reportedly between 90,000 and 120,000, depending on which agent member you talk to. So, yeah.
Okay.
Yeah.
Okay. So,
I mean, they expect to kick off.
They
do not say, though, that they are kicking them off the Medicaid roll. They say they're going to graduate them to employer insurance. So that is something that we have been messaging again to make that very clear that that's regularly what's happening. So just so everybody knows.
Thank you, Marcy. I think we've solved the problem. Everybody should be unmuted. So if you have a question, please jump in. Brent Robertson has a question. Next in line. Brent, can you hear us, and can we hear you? Nope.
Actually, my apologies. It's Susie Craig from Connecticut, and that's my fiance's name.
Okay. Hi, Susie. How are you? Very good.
Well, it's because we're on the same phone plan. That's why his name's coming through. But just a comment from, just so you know what's happening in Connecticut, we recently had a public hearing around a bill introduced around work requirements. We were fighting it last week, and all of this messaging that you presented is what we also were aligned with and presented. It seems to be working, so I'll have an update in another week or two as the hearings go on and our session continues. But a lot of it does seem to be working, especially when you flip the conversation around, costs and also, what's going to be lost and regards to benefits and just the sheer, infrastructure hits for implementing something like this. So just a comment to let you know that all this is working in Connecticut, I think, and I hope to have a more solid report in the next week or two.
Great. We love to hear what's going on in the states, share with each other. The conduit can be through your RPC rep or send it to me, Debbie Plotnick, or our advocacy manager, Karen Howard, and we will distribute it all across the affiliate network through our regional policy council reps. It's really helpful to everybody if we hear about what's going on, and we can share that with you all, and we can learn from each other. Other folks, we've got people in there.
Debbie, one last thing. One stat
Sure.
that we've been using in Connecticut is about 72% of Medicaid recipients are employed under age 19, over age 65, or have a disability that prevents employment.
What was that percentage, Susie? Say that again.
72% of Medicaid recipients are.
72%. That's really quite remarkable. So across the country, the average is about 60%. Some states like Connecticut, Colorado, it's those C states, they have a higher percentage of folks who are working in the expansion population. Some of the reason that some of the states are lower is that jobs are harder to come by in some of those states. That's also a factor here. And so that's in those states that have high unemployment rates, that's something also to mention. We've got a question from Mike Stoltz. Hi, Mike. Yeah, Ben might be better able to answer this. Here's the question. Senator Corker of Tennessee had undertaken an investigation responding to high rates of SSI and SSD fraud in Tennessee, and this was captured on a 60 Minutes report. Did anything come from that? Ben, do you know anything about this?
I actually do not know the answer to that. Okay. I do know that there are some fraud cases regarding benefit eligibility, supposedly, as well as prescription fraud, but I'm not quite sure what made 60 Minutes. I'll have to dig and get back.
Okay, we'll get back to you on that, Mike. Do our best on it. One of the things that's also difficult with respect to medical frailty, because there is no one definition, is that some states may go by people who have already gotten a designation of disability under SSI or SSD. And that's very difficult to obtain, and it takes sometimes some resources to get there, a lot of tries. But most importantly, to reach that designation of disability, you have to have a trail of having medical care that shows that you have a condition that is ongoing. And without any health insurance, that puts you in a conundrum. There's a number of catch-22s. That's one of them. Another one, as mentioned earlier, is that working might put you above the threshold for qualifying. Now, that in and of itself shouldn't be a problem. We want folks to make more money, but they might not have jobs that have benefits, or they might be home taking care of a family member or a young child. So sometimes having this requirement will put them in an untenable situation. Other questions, please? Can we hear other folks? Are we all open? Okay.
Debbie, I'll weigh in a little bit on what I think is actually something decent coming out of Kentucky, even though they're the poster child with the lawsuit right now. Kentucky is willing to allow outpatient support groups to qualify as active substance use disorder treatment. So they're considering the AA, NA groups as and double trouble type support groups as proof of participating in one of the exempt categories, which I think is fairly generous. The other thing that I think is instructional for folks is, despite SNAP programs all across the country having a work requirement for years, from 2008 onward, because of the economy, those programs froze the work requirement, and many of the states have started to add them back. And Kentucky, like Tennessee, has a number of economically distressed counties even though the economy is a lot better today than it was in 2008. So leaning towards the SNAP requirement still allows states to exempt certain areas of their states where the number of unemployed, the lack of available jobs in a community can still be used to exempt a particular community if a Medicaid program does enact a work requirement. So I think that's instructional for other states to consider too.
We are at our time, but if folks have other questions, we'll hang around another minute. Is there anybody else that has a question or a comment? And we will be keeping everybody informed through our Regional Policy Council and the cluster calls. This will also be an ongoing topic at our meetings, and we hope that you'll all be joining us for one of our meetings either in Los Angeles, New Orleans, or in Kentucky, Greater Cincinnati at the end of the year. I especially want to thank Ben and Shell for presenting today, and a big shout out to our advocacy manager, Karen Howard, that did a wonderful job with the slides and a lot of research for getting the numbers together for us. And just want to say that we are all here all the time and happy to answer questions individually about states or collectively about what we're hearing. So please feel free to reach out through your rep or reach out to us directly. So any closing things that you'd like to offer, Shell or Ben?
Thank you all.
I just typed mine in.
Oh, that was sweet. Shell said Karen rocks.
There you go.
All righty.
Yay.
Thank you all for joining us. We truly appreciate your participation, and we hope that you find the coordination that we're trying to do across states and within the states very helpful to you. So thank you all for joining us today. Bye-bye.
Bye.